Thank you. Could I have the slides, please? The interstitial lung diseases are a very important part of the practice, of the day-to-day practice of radiology. They account for about 15% of patients which are seen by pulmonary physicians, and therefore account for a significant component of what we all see in day-to-day practice. They're a very varied and heterogeneous group of disorders which have as their only common characteristic the presence of inflammation and fibrosis in the lining walls of the alveolar interstitium. Many attempts have been made to classify them. The classification which I think is most useful is divides them into the interstitial lung diseases of known etiology. There are over about 100 causes of interstitial lung disease, so it's impossible to list all those, but they're easily subdivided into those due to inhaled organic dusts, inhaled inorganic dusts, inhaled fumes and gases, and iatrogenic causes. Inhaled organic dusts include especially asbestos and silicosis, as you know. Inhaled organic dusts include a vast range of disorders classified loosely as the extrinsic allergic alveolitis group of disorders, and the patient on the left is a patient who has a very fine nodular infiltrate in her lungs, which I hope you can appreciate, confirmed on high-resolution CT, and this was found to be due to bird fancier's lung, one of the extrinsic allergic alveolitidae. The iatrogenic group of disorders, I think, is particularly important. These are especially due to drugs. The main group of drugs which causes interstitial lung disease is the chemotherapeutic drugs such as busulfan, methotrexate, cyclophosphamide, and also of increasing importance in the non-chemotherapeutic group is especially adriamycin or amiodarone. We're seeing a lot of patients now on amiodarone, and I think it's going to increase as experience with this drug increases. The interstitial lung diseases of unknown etiology are even more heterogeneous. They're basically classified on the basis of their radiologic, clinical, and pathologic features. The most common and probably the most important is idiopathic pulmonary fibrosis, which you see at the top there, and that's basically a constellation of findings, is based on a constellation of findings and the exclusion of a known cause for pulmonary fibrosis. It has a number of synonyms, including cryptogenic fibrosing alveolitis, Hammond-Rich syndrome. Many people use the terms UIP and DIP interchangeably with idiopathic pulmonary fibrosis, but I think it's important to remember that these DIP, UIP, and BIP are pathologic terms and are not synonymous with idiopathic pulmonary fibrosis. Sarcoidosis, as you know, is characterized by non-caseating granuloma, present usually in multiple organ systems. The lymphocytic group of disorders is a group which Dr. Goodman touched on this morning and is becoming of increased importance. The prototype disorder for this group is lymphocytic interstitial pneumonitis. That can present in a variety of ways, and its importance is increasing now. It's well recognized to be associated with Sjogren's syndrome, and more recently, as Dr. Goodman mentioned, to be associated also with the acquired immunodeficiency disorder, both in childhood and in adults. The patient on your left is a patient who had two risk factors for LIP. He was both a male homosexual who was HIV positive and also had Sjogren's syndrome, and he has a diffuse nodular lung infiltrate throughout both lungs and had, as I say, LIP on histology. This is important for another reason, because LIP is now known to be a pre-malignant condition, and between 5 and 20%, depending on what you read, will go on to frank lymphoma. So in patients with this diagnosis, it's important to watch for the development of adenopathy and effusions, which may herald the development of lymphoma. The basic underlying pathogenesis of all these very varied group of disorders is, as I mentioned, the presence of alveolitis. Alveolitis is the accumulation of inflammatory cells in the alveolar walls. And the various disorders have various characteristic types of inflammatory cells which can accumulate. The slide on your left is a slide of a patient who has alveolitis. You can see that there's very mild thickening of the septa in between the alveoli with inflammatory cells. And if I could figure out how to work this pointer. Sure. Sorry, here. You can see that the alveolar septa are thickened with infiltrate of macrophages in this case. The other important point is that not only are the macrophages present in the alveolar septa, which are diffusely thickened, but they are also lying free in the alveolar lumen. And that's one of the characteristic things about alveolitis, and it's the basis for one of the modern diagnostic techniques, which is bronchoalveolar lavage. Sampling the cells which lie free in the alveoli gives a good indication of the type and amount of cells which are present in the alveolar septal walls. In sarcoidosis, these are predominantly lymphocytes. In idiopathic pulmonary fibrosis, these tend to be neutrophils on the whole with some macrophages. And in histiocytosis X, we get a very special form of macrophage, which is called the Langerhans cell. But the underlying pathogenesis in all these cases is the same. The way these disorders cause fibrosis is by release of inflammatory mediators. This is the focus of a lot of research at the current time, and I think will become more important in years to come. The main inflammatory mediators which are discussed now are fibronectin and interleukin-1, as well as macrophage-derived growth factor. And very active research is directed, first of all, at preventing the release of these inflammatory mediators, and secondly, at preventing the subsequent fibrosis. Therefore, we see that alveolitis is an important concept for the radiologist to get used to. How can we evaluate this alveolitis? We have four basic ways. We can use open lung biopsy, bronchoalveolar lavage, gallium scanning, and high-resolution CT scanning, and I'll discuss each of these in turn. Open lung biopsy has long been regarded as the gold standard both for diagnosis and for assessment of interstitial lung disease. The alveolitis, it is, however, important to note that the validity of the open lung biopsy depends totally on the choice of the site which the surgeon has chosen for biopsy. He needs to stay away from areas of end-stage lung and also from areas of normal lung. This is an area, in fact, where the radiologist will have a role in the future. With high-resolution CT scanning, we can identify the best areas for choice of biopsy and guide the surgeon. And we've been quite successful in this. Transbronchial biopsy is obviously considerably less invasive. However, unfortunately, it's frequently nonspecific. It tends to be diagnostic in the group of disorders which are characterized by accumulation of cells around the bronchovascular bundle, especially sarcoidosis and lymphangitis carcinomatosa. In other disorders, though, it's of very limited value. So let's go to an example of a patient who has obvious interstitial lung disease. This patient has marked reduction in his lung volumes, which is a very important sign on plain chest X-ray. He has areas of cystic change at the bases, which probably represent focal honeycombing. But there's not much point in calling this man's physician and saying this man has advanced interstitial lung disease. The physician already knows that. What he wants to know is how should he be treated and whether he should be treated. This patient's gallium scan shows diffuse increase in uptake in both his lungs. You can see that the uptake here is considerably greater than that in the surrounding soft tissues, but considerably less than that in the liver. The uptake is great enough to cause a negative cardiac defect. And perhaps you could see that the uptake is particularly pronounced at the left base. This is the patient's high-resolution CT scan, which shows some evidence of honeycombing, especially posteriorly, and also these patchy areas of increased density, especially at the left base, which seems to correlate with the gallium scan. Now, increased uptake of gallium suggests an active alveolitis, and it's recently been shown in an article by Mueller that these areas of focal increase in uptake in patients with idiopathic pulmonary fibrosis also suggest that the alveolitis will be active. Therefore, this man, though he has considerable areas of end-stage lung disease, still has active alveolitis and should be aggressively treated with corticosteroids or immunosuppressive agents. Biopsy subsequently confirmed that he had an active alveolitis due to idiopathic pulmonary fibrosis. We've mentioned gallium scanning. Gallium is of importance because it's taken up in the lung largely by macrophages. We know that it can be more sensitive than the chest X-ray. We've all seen this in cases of pneumocystis, where the chest X-ray can be normal with an abnormal gallium scan and a high yield of pneumocystis on biopsy or lavage. In idiopathic pulmonary fibrosis, the intensity of uptake in the lungs correlates very well with the extent of alveolitis found on biopsy. And therefore it's important both for initial assessment and following patients with idiopathic pulmonary fibrosis. Steroid treatment can significantly reduce the uptake. In sarcoidosis, the pattern of uptake is often typical, and I'll show you an example of that. However, in sarcoid, the prognostic significance of a positive gallium scan is less certain. One may have a positive gallium scan without other evidence of active alveolitis. Overall, I think it's very useful as a complement to bronchoalveolar lavage because gallium measures the macrophage component of alveolitis. This is a typical patient with idiopathic pulmonary fibrosis who has diffuse increase in uptake in both his lungs, again considerably greater than soft tissues but less than liver, so moderate or grade 2 to 3 positive gallium scan. This is an example of the typical pattern of uptake which we see in sarcoidosis. You can see evidence of bilateral hilar uptake, which is symmetric, and bilateral salivary gland and lacrimal gland uptake. And this pattern, when seen in the typical clinical setting, is almost diagnostic of sarcoidosis. Bronchoalveolar lavage we've mentioned several times, and is based on sampling these alveolar cells, which are so important in the pathogenesis of alveolitis. As I mentioned, it gives a very good reflection of the intensity of the alveolitis. The type of cell which we find on bronchoalveolar lavage can help to characterize the disease. As I mentioned, in sarcoid it tends to be a lymphocytic predominance in the especially T lymphocytes in the lavage, while in IPF it in general will be in neutrophilia. And the type of cell and the intensity of alveolitis has important prognostic significance. The other thing is that bronchoalveolar lavage, though invasive, is a repeatable test and therefore can be used to follow the response of the patient to treatment. Now, the chest X-ray has a very useful role to play in interstitial lung disease, but it has several significant problems. The first is that, as we all know, it may be normal in up to 10% of patients who have biopsy-proven interstitial disease. This figure is from Epler's study. And he gave 3 possible reasons for that. First of all, the interstitial disease can cause such diffuse and homogeneous increase in density that it is very difficult to detect on chest X-ray. And the dominant cases which he saw in this group were desquamative interstitial pneumonitis and allergic alveolitis. About 20 to 25% of both these disorders were associated with a normal chest X-ray in his series. Also, interstitial disease can focally affect the small airways, causing disease not significant enough to be seen on chest X-ray, but causing severe abnormality of pulmonary function tests. This happens in bronchiolitis obliterans and in lymphangiomyomatosis. Also, the lesions may be too small or too focal to be visible on a chest X-ray. This patient on your right presented with mild dyspnea. Chest X-ray was normal, but its high-resolution CT scan shows moderate interlobular septal thickening at both bases posteriorly. This is a prone scan, so this is not due to dependent distension of the veins. This patient had mild interstitial fibrosis on biopsy. This case represents another problem. She's a lady with long-standing Wegener's disease who has scarring at both her bases, which was secondary to the Wegener's disease, also elevation of her left hemidiaphragm. She presented with new onset of quite severe and significant dyspnea, and her chest X-ray showed no new changes from her previous films. However, again, we performed a high-resolution CT scan. In this case, you can see that there is very widespread, rather patchy areas of increase in density in both lungs, pretty diffusely. And on biopsy, this was found, in fact, to be due to lung damage due to cyclophosphamide. This raises an important point because many patients with interstitial pulmonary disease and vasculitis are now being treated with immunosuppressive agents, including cyclophosphamide and methotrexate, and therefore it is important for the radiologists to be aware of other possible causes for their dyspnea other than progression of their lung disease. Likewise, the chest X-ray, as we know, may be severely abnormal with normal lung function. This tends to happen especially in sarcoidosis and in uncomplicated pneumoconiosis. This is a patient who has extensive abnormality on her chest X-ray. Surprisingly, her lung volumes and her diffusing capacity were entirely normal. This is her high-resolution CT scan, which again shows extensive abnormality in both lungs. This is, in fact, the pattern which we tend to see in sarcoidosis, with focal areas of increased density, some nodularity, and clustering of the abnormality around the bronchovascular bundle. This patient was found to have sarcoidosis, and the explanation for her normal diffusing capacity seems to be that the sarcoid, though extensive, did not affect the alveolar interstitium sufficiently to cause abnormality of gas exchange. I've mentioned high-resolution CT scans several times, and Dr. Gamsa will talk about this later, so I don't want to spend too much time on it. But we've identified several areas where high-resolution CT can be extremely useful. It can be used to investigate unexplained abnormality of pulmonary function, to assess the activity of alveolitis, as I've mentioned before. This is another patient who presented with an abnormal chest X-ray, and his high-resolution CT scan again shows very widespread, patchy increase in density, more marked on the right than on the left. He was found to have UIP with diffuse thickening of his alveolar septa, again with an active alveolitis, and again was treated aggressively with immunosuppressive agents. These are two patients, middle-aged men, who both presented with abnormal pulmonary function tests, impaired diffusing capacity, and a normal chest X-ray. This is a group, I think, which we'll be seeing more of as more and more patients are referred for screening pulmonary function tests. And it represents a major problem for the pulmonary physician. Does he just reassure this patient and ignore the result of his test, or should he follow them, or should further investigation be indicated? I think high-resolution CT scanning has a major role to play in these patients. The patient on this side, as you can see, has evidence of early thickening of his interlobular septae, again posteriorly in the non-dependent lung on a prone scan, suggesting early interstitial fibrosis. Patient on this side, on the other hand, has widespread areas of focal low density clustering around centrilobular vessels, and more marked in the upper lobes than in the lower lobes, and this is the pattern which we tend to associate with centrilobular emphysema. So I think high-resolution CT scan has a very useful role in triaging this particular group of patients. This patient certainly has an abnormal chest X-ray. He's a very fine nodular infiltrate, He presented with very marked dyspnea. His high-resolution CT scan shows that in addition to the fine nodular infiltrate, he in fact has very widespread areas of honeycombing. His lung is practically filled with very fine honeycomb cysts. This patient had end-stage lung. And this again is a very important diagnosis to make because it implies that no treatment apart from heart-lung transplant will benefit this patient significantly. He has end-stage lung due to histiocytosis X. The other uses which we found for high-resolution CT scan is that we're just beginning to learn the different patterns associated with different disease processes. As I mentioned, we can also use it to identify a suitable site for biopsy in patchy lung disease, and we can use it to observe the progression of disease or the response to therapy, as I hope to show you. This patient on the right shows the pattern which we've come to associate with lymphangitic spread of carcinoma. He has thickening of his fissure, marked thickening and coarsening of his bronchovascular bundles with nodularity, and also thickening here, nodular thickening of his interlobular septa between the secondary pulmonary lobules, and also nodules visible within the secondary pulmonary lobules. It's quite a good example of the pattern, of this pattern, which is characteristic again in an appropriate clinical setting. This patient presents with an abnormal chest X-ray and a high-resolution CT, which shows a predominantly nodular pattern again. You can see that the nodules tend to cluster peripherally in the subpleural regions. They also tend to cluster along the interlobular septa and to some extent around the bronchovascular bundles. And this is another example of sarcoidosis. The open lung biopsy from this patient shows why we see these findings. There are widespread non-caseating granuloma infiltrating this interlobular septum, which I suppose you could fancy corresponds to that, and giving it a sort of a nodular pattern. They are also clustered subpleurally and around bronchi and vessels. This is the typical pathologic findings for sarcoidosis, and this is the findings which we've come to associate with this on high-resolution CT. Other patterns which we can see with sarcoidosis include just diffuse increase in density and with some nodularity. This is probably due to multiple very fine granulomas just obliterating the normal structure of the lung, but we can't distinguish that from thickening of the interlobular septa. At a later stage of sarcoidosis with fibrosis, we get a very characteristic clustering and cicatricial crowding of bronchi and vessels centrally in the lung. This is an example of how we can observe progression of disease. This is a 68-year-old man who presented with dyspnea and has had an abnormal chest X-ray. His initial high-resolution CT scan shows evidence of thickening of his interlobular septa, especially posteriorly here, and also in the right lung. There are focal areas of increased density also, and these did not clear when the lung was turned dependent. Here are more areas of thickening of his interlobular septa. 4 months later, he came back with marked progression of his disease. Unfortunately, he had not been treated in the interim, and you can see now that he has very dramatic increase in his septal thickening in areas which were not affected previously. In certain areas here you can see an interlobular septum outlined by thickened, or a secondary pulmonary lobule outlined by thickened septa. And within that structure you can also see that there are thickened lines suggesting that there is also fibrosis along intralobular septa. So this man has extensive and progressive interstitial fibrosis, and in fact, unfortunately, he died subsequently following an open lung biopsy and was found to have IPF with an active alveolitis. Again, the active alveolitis was suggested by the focal areas of increased density. So I hope that I've shown to you that the role of the radiologist is very important in the assessment of interstitial lung disease. The chest X-ray remains of great value in the diagnosis of interstitial lung disease and in its characterization, but gallium scanning is it may be more sensitive than high resolution than chest X-ray in certain contexts, and likewise high resolution CT scan may show disease where none is seen on the plain film. For characterization of disease, I think chest X-ray still has a very large role to play, but high-resolution CT scan is also beginning to show us certain patterns associated with, characteristically associated with certain types of interstitial disease. For measuring activity of alveolitis, gallium scanning is certainly useful, and again, high-resolution CT scan is useful in complement with biopsy and bronchoalveolar lavage. And for monitoring the progression of the disease, chest X-ray is useful, but gallium scanning and high-resolution CT scans, I think, have a major role to play here, especially as people get more aggressive in treatment of interstitial disease to prevent the sequelae which I've shown.